Right. So today I'll be talking on this very important topic, maintaining cerebral perfusion pressure in traumatic brain injury. So this talk was given by me in September 2017 in Trivandrum in one of the meetings. So all the review of literature would be dating until 2017. So any changes may not be there in this particular talk. So basically what we need to understand is the whole question of cerebral perfusion pressure and ICP is in the setting of a traumatic brain injury. Our intent is to minimize secondary injury. I think that is our primary goal. So I think there are two important ways that which govern our ability to minimize secondary injury is maintaining good cerebral perfusion pressure and maintaining good cerebral oxygenation. I think these remain the important tenets of managing traumatic brain injury and avoiding secondary injury. So if you look at the brain, I think in traumatic brain injury, the brain, since it is injured, there is increased requirement of oxygen and glucose. So this is the basic premise in traumatic, that the requirements for this oxygen and glucose tends to increase, and this happens in the setting of failure of metabolic substrate storage that happens in traumatic brain injury. So in the phase of depleting storage substrate, so then the demands for increasing in the oxygenation and glucose increases. So in that, so there is a compromise in oxygen and glucose supply in the brain, and together with this it leads to ischemia of the brain. So this is the basic pathophysiology that tends to occur in traumatic brain injury. So why is cerebral perfusion pressure important? See, what we have tried to correlate is cerebral perfusion pressure is taken as a surrogate or as an indicator of cerebral blood flow. So here again we are trying to have a linear correlation between the pressure and flow. So in intensive care, I think this is where we have had problems. So we are attributing cerebral perfusion pressure as an indicator of cerebral blood flow. So in early phase of any traumatic brain injury, there is increase in the intracranial pressure. So as we know, cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So when there is increase in the intracranial pressure, so there is reduction in the cerebral perfusion pressure, and because of this we understand the cerebral blood flow is curtailed, and because of that there is a reduction in the jugular venous saturation, which is an indicator of brain tissue oxygenation. So, so what are the determinants of cerebral oxygenation? So the oxygenation to the brain is determined by three factors. One is oxygen content of the blood in the brain, and oxygen consumption by the brain, and cerebral perfusion pressure or the cerebral blood flow. So basically your whole oxygenation of the brain is determined by these three factors: oxygen content, oxygen consumption, and cerebral blood flow, which is indicated by cerebral perfusion pressure. So simply calculating cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. But I think one important thing what I want each one of you to understand is, although your cerebral perfusion pressure is an indicator of cerebral blood flow, what we need to understand is this cerebral blood flow, there are a lot of autoregulatory mechanisms in the brain which determine this cerebral blood flow. It is not only the cerebral perfusion pressure we determine this auto, because every brain has its own autoregulatory mechanisms in which your cerebral blood flow is coordinated. So what that means is, the in normal autoregulation based on hypoxemia or hyperemia, there is a constant altering of the resistance of the cerebral blood vessels that keeps happening. And in the face of this, I think the perfusion of the brain is determined. So there are normal autoregulatory mechanisms, and our understanding is how effectively this autoregulation is happening will determine the effectiveness of cerebral perfusion pressure. So it is not like your cerebral perfusion pressure has a direct linear correlation with cerebral blood flow, because that another important determinants of cerebral blood flow is the autoregulatory mechanisms present in the brain. And as I mentioned, so if we believe that cerebral blood flow is directly proportional or correlative or has a linear correlation with cerebral perfusion pressure, there is another important pressure which it is inversely proportional. So cerebral blood flow is inversely proportional to cerebrovascular resistance. So obviously if your cerebrovascular resistance is high, then your cerebral blood flow is low. If this is low, then your cerebral blood flow is getting better. So this is the relation we have understood. And this auto regulation, so what controls auto regulation? I think our cerebral auto regulation is controlled by all these elements. So it's metabolic, myogenic and neurologic. So it is a complex internal milieu that influence your auto regulation, and I think we have poor understanding of these abilities. So this is all internal body's adaptive response that happens, and I don't think we have absolute control over these mechanisms, because these are all internally regulated and it is all determined by the host mechanisms. Okay, so if you, what do we understand by this auto regulation? So if you look at this curve, so what this graph, what it shows is your this is cerebral perfusion pressure, this is the cerebral blood flow. As you see, as your cerebral blood flow keeps increasing, so there is at one stage your cerebral perfusion pressure sort of cerebral blood flow gets plateaued even in the face of increase in the cerebral perfusion pressure. So there is maximum dilatation at the outside, then slowly it sort of plateaus. Your blood flow even in the face up to 60 is the threshold. Up to 60 increase, there is increase in the cerebral blood flow. So but after 60, even your increase in cerebral perfusion pressure is not leading to increase in the cerebral blood flow. So that's why our threshold for cerebral perfusion pressure, all the studies, if you look at it, have looked at cerebral perfusion pressure between 50 and more than 60 or maybe 70 or 80, because we have realized further increase in that does not really make any difference in the cerebral blood flow. But after supranormal change in the cerebral perfusion pressure, I think then you may have another peak there with increase in the cerebral blood flow. That's where maximal constriction of the cerebral blood vessels would happen. So we are looking at the therapeutic intervention between 50 to maybe more than 60 up to 70 or 80, because after that we do not have any studies done, because we don't believe further increase up to 150 leads to any change in the cerebral blood flow. So that's, we'll review the studies, that's when you realize why we have got this arbitrary number of 50 to 70. Okay. So let's look into the alterations of cerebral perfusion pressure in injured brain. So since we have spoken about auto regulation in the brain, so we need to understand what are the problems that will affect the auto regulation. So this auto regulation, which I said is very important, which determines cerebral blood flow, is impaired in the setting of hypoxemia, hypercapnia and anesthetic agents. So your auto regulation can be affected with these, and which we know these are all, I would call it as normos in treating traumatic brain injury, where we know that hypoxemia is bad in traumatic brain injury, hypercapnia is bad, because we know these can cause secondary insults, and these also have bearing on impairing autoregulatory mechanisms, and that leads to cerebral ischemia. And we know for sure that cerebral ischemia can be accentuated by even reduction in blood pressure, reduction in mean arterial pressure. So your cerebral perfusion pressure is affected predominantly by two factors: reduction in MAP, because as I said, CPP is mean arterial pressure minus ICP. So if your MAP comes down, your CPP comes down. If ICP increases, your CPP comes down. So that is quite intuitive for us to understand. So CPP, ideally the critical threshold for CPP is mentioned as 50 millimeter mercury, and it is expected that we maintain more than 50 because of the previous graph you saw, because after 50 only your cerebral blood flow is optimal. And when there is increase in intracranial pressure, so your perfusion gets affected. So what we have understood is when there is increase in CPP, I think your intracranial pressure is expected to come down. How does it come down? So by reduction in the vasogenic edema. So there is a lot of edema in the brain which tends to come down by reduction in CPP, and there is reduction in the cerebral volume, blood volume. Cerebral blood volume tends to come down. So Rosner et al. Has shown that CPP more than 70 can lead to increase in the cerebral blood flow. So this was one of the study which they said more than 70 your cerebral blood flow is much better. Okay. And the increase in the cerebral blood flow can cause hyperemia, and that hyperemia can increase vasogenic edema and increases the ICP. So this also is found to be deleterious. So that is where our whole studies are aiming at pressures between 50 and 70, because less than 50 you are not you are not achieving good cerebral blood flow. So more than 70, I will talk about all the studies, So they have found deleterious effects with more than 70 because of over increase in the cerebral blood flow, which may lead to worsening of the cerebral blood edema and increase in the ICP. So too much high is also bad, and less than 50 also is found to be bad. Okay, so we look at rationale for use of ICP and CCP directed therapy. So ICP directed therapy, I think now we know there is a controversy of whether ICP monitoring will help or no monitoring. So let's look into what is the evidence. So these are all some of the studies from US and UK. So some studies have shown that ICP monitoring achieves better outcome. And when we are monitoring ICP, our intent is to maintain ICPs less than 20 millimeter mercury, and ICPs, if it is more than 20 millimeter mercury, I think we all know that it has to be brought down and it leads to deleterious effects. So we need to manage uh, effectively to reduce ICP and improve the CPP. But the problem with the whole ICP is you keep the ICP monitor for more than 3 days, there is increased risk of infections, and this risk outweighs some of the benefits of ICP in some of the studies. So this is a summary of 6 randomized controlled trials and 12 cohort studies. What they found is using ICP to manage your CPP and your traumatic brain injury has shown to reduce electrolyte abnormalities, reduce acute kidney injury, and has had a good favorable outcome. But use of ICP has not shown any effect on mortality, ICU length of stay, mechanical ventilation, or even infections. I think if you vouch for this meta-analysis which was done with 6 RCTs and 12 cohort studies. So this is the current understanding. So ICP conclusively there is no evidence to say that ICP changes outcome in the patients. I think that we have understood even from the recent studies. So I think the target, why we are interested in optimal cerebral perfusion pressure. So we are interested in trying to determine what is the exact target we need for as a optimal CPP. So the reason why we need this is to reduce this ischemic penumbra. We have understood if CPPs are maintained well, so our understanding is we have ability to reduce this ischemic penumbra so that we can salvage more of the cerebrum. And we have understood by managing CPP effectively with optimal cerebral perfusion pressure reduces the release of free radicals in the brain. So there are excitotoxic transmitters of free radicals that are released which can cause a lot of brain injury. It has been shown with effective CPP you can mitigate the release of these free radicals and you can reduce inflammation in the brain. So this is our understanding as to why we are all aiming to achieve what we believe is an optimal CPP. But we do not know what is the optimal CPP at this point of time. But what we have understood is we don't want it to be low. Less than 50 we have understood we do not achieve good cerebral blood flow. More than 70 we know it can be bad because it increases the cerebral blood flow, it can increases the vasogenic edema and increases the ICP. So we are in the business of trying to understand what is the right CPP for a patient. So what is the Lund therapy? So Lund therapy is basically we have understood by reducing ICP, our whole intent is to reduce the vasogenic edema. So the Lund therapy talks about reducing CPP, not maintaining very high CPP. With an intent we reduce the vasogenic edema because we know more than 70 it worsens the vasogenic edema, and by reducing vasogenic edema our assumption is it reduces the intracranial volume, okay, and it reduces the ICP. So this is our understanding of the Lund therapy, because we do not want high CPP so that our vasogenic edema and hyperemia doesn't happen, your intracranial volume comes down and your ICP comes down. So the Lund therapy proposers or the pundits would say that CPP obviously it cannot be less than 50 millimeter because less than 50 causes reduction in the cerebral blood flow, and more than 60 it has shown to avoid brain hypoxemia or brain tissue oxygen reduction. It avoids by maintaining more than 60. So what we understand is less than 50 is dangerous, but we need to maintain it more than 60 to avoid brain desaturation, or this is brain tissue oxygenation, to avoid reduction of the brain tissue oxygenation. But we have understood more than 70 also may not be good. So this is where all the studies have been done to see what is the right number we need to be targeting.